So anorexia nervosa. So this presentation will be covering anorexia nervosa within psychiatry. Probably a fairly common presentation within GP, so awareness is super important. During this presentation, we'll be looking at what it is, how it presents, what the signs and symptoms are, how we best investigate it, how we assess the risk, and then management for those individuals. People with anorexia nervosa tend to maintain a low body weight. Now, this is generally because of a preoccupation with weight, either because they're afraid of gaining weight and being fat, or their desire is to be thin. But in people who suffer anorexia, they lose sight of reality and are terrified of becoming fat, despite the fact they might be a normal weight and shape. And the way the diagnosis tends to be made more clinically and from your history, and particularly your history and your examination. We know that it's more common in females and males than males. So the number is thought to be about 9 in 1,000 females that will suffer from the condition in their lifetimes, and it affects women to men at a 10-to-1 ratio. But this is thought to be the case because actually men are either misdiagnosed or undiagnosed and also under-referred. The typical age of onset in these people tends to be mid-adolescence, and we know it's also a multifactorial issue. So your social, your biological, your emotional and your genetic factors will all contribute to your predisposition to suffering from anorexia nervosa. So I know we've touched on a few risk factors already, but age, so being in that adolescent group, being female, previous abuse, so physical, emotional or sexual abuse, social pressures, so if the group of people around you or the individual are encouraging or also desiring to be thin, that might influence the patient. Again, that fits in with occupational, recreational pressures, so that could be in dancers, gymnasts, models or jockeys. An individual's criticism or perceived criticism about their weight or eating behaviour can make them feel like that, and living in a Western society particularly is a risk factor. Any family history of an eating disorder, depression or previous substance misuse can predispose you. And then I just mentioned personal characteristics. So this could be that the person in question seeks perfection. They don't have a very good view of themselves. They have low self-esteem. They were obese as a child, or they could have features of obsessive compulsive disorder. They may have personality disorders or suffer from anxiety and have coexisting mental health problems. which can all predispose to anorexia. So when we're thinking about the presentation of anorexia, it is the refusal to maintain an appropriate body weight for that age and their height. So in adults, a weight below 85% are predicted. So this means in adults that's a BMI of less than 17.5, but obviously for those under 18 that will vary, and you can use the BMI centile charts to predict that. They may come with mum or dad or a friend who may alert you to the fact that their eating habits have changed, they're dieting or they're restricting their eating or they're excessively exercising, that their lack of desire for intervention or even resistance to people trying to change those ways might be present. They might have become socially withdrawn, have fewer interests. They may experience abdominal pain or cold intolerance. They're likely to have an obvious fear of gaining weight and will often have a period of rapid weight loss. In women particularly, you may suffer amenorrhea. Thinking about investigations, of course, height and weight to calculate the BMI is the number one thing that should be done. Ensuring that core temperature and a full cardiovascular examination is done, so checking the pulse, blood pressure, and checking for postural hypotension. You want to test the muscle power, and you also want to test to exclude organic causes. So I mentioned thyroid function there. So the bloods you should be thinking about doing are UNEs, FBC, CRP, ESR, glucose, creatinine, and your thyroid function tests. And UNEs should be checked in all those with behaviours such as vomiting and taking laxatives or diuretics or possibly water loading. I just wanted to mention a bit in the examination, as well as noticing a bradycardia or a low blood pressure, just your observation of the patient. So they probably are likely to have a gaunt face, and there would be signs of also lanugo hair and also scanty pubic hair. DEXA scans are really important for looking at bone, and ECGs may also be helpful. They might show a bradycardia or a prolonged QT interval, but that tends to be in more severe anorexia. So assessing risk and management. So the management of really sick patients with anorexia nervosa is a risk assessment framework. So in adults, in those aged 18 years or over, the following parameters suggest severe anorexia. So a BMI of 13 to 15 conveys medium risk. A BMI of anything less than 13 is high risk. If the rate of weight loss is more than half a kilogram per week, if the pulse rate is below 40 beats a minute, if the systolic blood pressure is below 90 and the diastolic blood pressure is below 70 with a postural drop greater than 10, if the patient is unable to get up from a squatting or lying down position without using their arms for balance or leverage, if their core temperature is below 35 degrees and the blood test may demonstrate hypokalemia, hyponatremia, hypomagnesia, or hypophosphatemia. You may also expect to see a raised urea, creatinine, and a low albumin or low glucose. And I mentioned about the prolonged QT interval in those individuals, the severe anorexia nervosa individuals. In children under 18, so in children and young people, the risk parameters do need adjustment for their age and their gender, because obviously their physiological measurements such as pulse and blood pressure vary from age to age. So signs of moderate and severe risk, and this would suggest need for acute admission, would be a BMI, so median risk is 70 to 80% of median BMI, and a high risk is less than 70%. So the rate of weight loss, a median risk is suggested by recent weight loss of 500 to 999 grams per week for 2 consecutive weeks, and high risk is 1 kilogram or more over the same time frame. A pulse rate below 50 is medium risk, and below 40 is considered high risk. If the patient's presenting with cardiovascular symptoms, for a history, for example, of syncope and or postural drops in blood pressures, an increase in the QT interval of 460 for girls or 400 for boys suggests a medium or high risk. A core temperature of less than 36 suggests medium risk, and less than 35.5 suggests high risk. Blood tests are very similar to that as for adults. In terms of their behaviour, severe restriction of calorie intake, moderate to high levels of excessive exercise, food restriction, vomiting, purging, lack of insight, violent rebellion, and suicidal behaviour is also considered high risk. And again, if the patient is unable to get up from a lying down position or from squatting without using arms or balance for leverage. So in terms of management, again, it differs depending on whether you're an adult or you're a child. For those under 18, Anorexia Nervosa focused family therapy, also known as FT-AN, is considered first line. And then in adults, individual eating disorder focused CBT, Maudsley anorexia nervosa treatment in adults, or specialist supportive clinical management are all used within the community. Urgent admission is required if indicated. So if there is an electrolyte imbalance or a hypoglycemia, if there's evidence of severe malnutrition or dehydration, if there's evidence of coexisting organ failure and a bradycardia of below 40 beats a minute, or a prolonged QT interval, a very, very low BMI, or rapid weight loss, more than 1 kilogram per week for more than 2 consecutive weeks, if there's a need for medical stabilisation and refeeding, or if there's an inability or incapacity of parents or carers to provide the support needed. And again, if there's a significant suicide risk, you would think about admitting the patient. In the community, it's important to think about what other things can be done. So multivitamin and mineral supplements should be advised, so long as it's providing all the necessary nutrients. Dietary advice should be given. Medication isn't advised for the sole treatment of anorexia, and you would obviously try to advise the avoidance of excessive exercise. We've touched on many of the complications at the point at which the disease becomes severe, but there are a couple we haven't touched on: thrombocytopenia, anemia, mitral valve prolapse, peripheral edema, constipation and infertility, renal calculi and possibly AKI are all complications of the problem. It has a pretty variable prognosis, but it has the highest mortality rate of all the psychiatric conditions, but this is predominantly due to the medical complications and also the increased risk of suicide.